Hey, welcome to the Anatomy of Therapy podcast. I'm Dr. John Cybulski here with Bobby Riley in frigid Iceland. I'm in not frigid Texas today. And we wanted to get into a fairly popular topic these days and maybe dissect it a little bit, thoracic rotation. A couple of things we're going to go over today. Why is thoracic rotation important? I'm going to figure out where the connection is, right? Then we want to go over what really is thoracic rotation, like specifically what is it? Hopefully we'll give you some complex ideas and then boil them down to some simple, more relevant day-to-day stuff. And then 3, how does thoracic rotation become dysfunctional, right? We need to know that. And then ideally after that, how do we improve thoracic rotation? So, daily activities, kind of behaviors that people get locked in. You'll find that patients will ask you this all the time. How did I get here? How do I get out of here? So getting in there, daily activities and behaviors, and then the mirror of that, treatment and rehab, how to kind of correct this. And then last, what if thoracic rotation won't improve? What if thoracic rotation improves but doesn't help your condition? And so what does it look like? What are things to go on from there? But to start off, I'll just kind of pose it to you, Bobby, really quick. Why do you, and then I'll take my stab at it. Why do you think thoracic rotation is important?
Well, I love how John comes up with certain questions and then poses them to me. It's always the best.
Yeah. Just force you. It depends, is what Bobby wants to say. And what does thoracic rotation depend on? We've done enough of these episodes now.
Yeah.
I love it.
Well, okay. So, the thoracic, we get rotation from the thoracic spine. So, that's one thing. We don't get that much from our lumbar spine. And even, in our cervical spine, most of that comes from like C1 area. So, we need that 35 degrees, or I guess if we take it both directions, 70 degrees, you need access to that because we have access to it, which means we probably have it for a reason. I'm sure there's some, the smart cats out there where they take this back to some kind of evolutionary history of where we needed it. But, an upright gait, you need to swing. In other words, you swing your opposite arm and leg with each other. So there's some rotation just required for normal gait. So just to be a walking human, which actually we don't need to do as much anymore.
True.
Sadly. So maybe T-spine rotation will be, if we fast forward 150 years, everybody will be like the people on Wall-E. Floating around in like a hover chair and sipping food out of a cup, and we don't really need thoracic rotation at that point.
Right.
So, but the straightforward answer right away would just be gait. I'm constantly letting patients be aware of the fact that when they walk, they don't swing their arms. And then I say, there's nothing aesthetically required. Like, I don't care if you swing your arms from an aesthetic standpoint, like it looks better to swing your arms. Sure. I just mean, if you don't swing them, you're either, most likely the reason you don't swing them is because you're not rotating. And if you're not rotating, you don't need to swing them. So you just hold them at your side and walk kind of like a robot. But those patients also tend to present with tightness and like, hurts between my shoulder blades. I get headaches. I'm very tired after I stand too long, after I sit too long. Even after I go for a walk, my back feels tight. They tend to have that concomitant presentation.
Right. Yeah. I was thinking with the arm swing, I used to not understand why, a doctor would watch a patient walk down the hall and be like, well, you see your right arm is not swinging. Your left arm kind of is, or vice versa. A lot of times it's one, sometimes you're right, it's none. Until I kind of realize it is a reflection of if that spine, like your arms are kind of dangling off of your rib cage, right? And if your thoracic spine is rotating, then your arm swinging would be swinging off a thing that is rotating, and that would be the spine. If it is not rotating and you're like, yeah, I'm stiff in my back and my shoulders and neck, obviously, there's not rotation there, and that is reflected in those arms not being able to swing. The other big thoracic rotation thing, I think, is for your patients as well. If you have a patient who reaches forward, backwards, and has pain or has a problem or dysfunction, thoracic rotation is a big piece of reaching, right? One arm goes kind of ahead of the other, or I've plenty of times people will be like, I was reaching back, to grab my kids or in the car, whatever it is, and pain. So if you are a human and you walk and you don't swing your arms, that's one of the signs, or you reach, then thoracic rotation may be of importance to you. Stick around for more big tips like that. Go ahead. What do you say?
Well, I would say the third one would be in athleticism.
Yeah, there you go.
I mean, if you just think of somebody like Barry Sanders, there's no way that you can, load a hip or load a leg like he could do and plant and rotate and, evade tacklers and all these things without thoracic rotation, because you can't really get into your hip without thoracic rotation. What I mean to get into your hip, which would be like load it and center it at the same time,
right,
so that it's powerful to explode off of. So you're very quick, you're very powerful from that position. And if you can't rotate, you can't really load the hip unilaterally very well. So or you could take it to even beach volleyball, and I forget their names now, but the two women that were dominant forever, they were amazing.
Right.
But like,
I could see them with their K-tape on their shoulders. And
oh yeah. I feel terrible not remembering their names right now, but
I can't remember
like
either.
the ability to jump and turn and hit and spike, but also keep both feet planted in the sand and like dig for a ball, like in a deep squat with a slight rotation off to one. I mean, it's endless examples for why you need to be able to rotate to play sport.
Athletically, baseball is a big obvious one. Yeah, I mean, throwing a ball, all of that. So many different things. Change of direction. That's basic athleticism.
Martial arts, throwing kicks, punches. Yeah.
The list goes on and on. The benefits.
Mike Tyson is fighting again. Did you know this?
I saw him training, or I saw him ripped.
Yeah. He's fighting Roy Jones Jr. For this kind of catch weight old man's division. Awesome. 8-round pay-per-view explosion. I think it's at the end of November.
That man can coil up some thoracic rotation and release some force.
He still can. Wasn't the videos amazing?
It's crazy. It's scary, but he's got 54. Some thoracic rotation. I'll tell you that.
He does.
Okay, so getting into a more doctorly sense of things, going to number 2 here. Maybe we'll get into a little bit of the structure. I'll try to go through some of it, and then Bobby can fill in the gaps since I threw you under the bus under that first question. But point 2, what is thoracic rotation then? So thoracic rotation is your thoracic spine, the rib cage, T1 through T12, twisting back into the right or back into the left. One of the reasons I liked thoracic rotation was I kind of saw it as this was bigger when I came out of school, but the hack, a big hack to get a lot of things done. So in thoracic rotation is always a combination of movements. Side bending. So let's say the right side is you're rotating back into the right. So you have, let's say this is right thoracic rotation. You are getting right thoracic extension. You're going to get some right thoracic side bending, but then the opposite stuff happens on the front. So if you're getting right thoracic extension and rotation and side bending going back into the right, the left side is doing the opposite. So the left side would be flexing kind of forward. Going back would also, thoracic rotation back would also be ER of some ribs. And this is also general. There are some more specifics, and we can kind of get into those with the ribs. It's really fun, actually. It's really fun. Ribs are fun. But basically, those ribs go back, and you want to think of them ER and rotating back and extending, and the other side's kind of flexing forward, and vice versa on the other side. So the big complex part, Bobby kind of brought it up a little bit earlier about how the lumbar spine doesn't really rotate that much, and the lower cervical spine doesn't really rotate that much. So most of the rotation should happen within that big barrel of the rib cage. And if you don't have that thoracic rotation, you'll usually try to get it elsewhere. You may, this is where your shoulder blades might flare out, so wing scapula. You might get over rotation of the neck. It happens a lot in the lumbar spine. The lumbar spine is only 5 little segments. And man, Dr. Spina does a great job of talking about their motion. There's just not much. From like 5, it's like 1 degree, 1 degree, 2, 2, and 3, going up from 5, 4, 3, 2, 1. So it kind of goes opposite of their numbers, how much they move. So they shouldn't move much. If they are moving too much, you get some like unilateral QL pain, it is a good sign that you probably don't have ipsilateral thoracic rotation on that side. One of the bigger things of what is thoracic rotation that is, I think, overlooked, and I kind of want your help with this, Bobby, because I know you got this down, is breathing. I once heard someone say one of the easiest places to move in, the most malleable places to move, is the rib cage. All you need to do is take a breath and it moves, right? It should, right? What happens to the thoracic spine? Let's just keep it simple when you breathe in and when you breathe out, generally and ideally and hopefully.
Yeah, I mean, so ideally, you would be getting a lot of that help from the diaphragm. So as you take a breath in, the diaphragm descends, and the diaphragm is dome-shaped, a bit like a umbrella kind of idea. And so it's attaching to the front of the spine, and it's attaching to the back of the sternum, and posterior aspect of the anterior rib cage, right?
Yep.
So as it descends, it should expand you in all directions. So as it pulls down, your kind of anterior to posterior dimensions will go up, and also a little bit from like side to side, from right to left will also expand. That should be what's kind of going on with the diaphragmatic breath. And a lot of times, like with people that are too tight in their posterior, paraspinals or rhomboids or lats, they're very extended. Some of these people, you can see very wide infrasternal angles, very flared anterior rib cages. You'll get a little bit of the opposite. You'll get people that breathe kind of more anterior and superior. So they breathe up into their chest. They breathe very high. Sometimes I'll have people lay prone or supine, and just put my hand around T6, 7, 8, 9, 10, somewhere around there, and just have them breathe in. And the dysfunction would be that they lift off my hand as they breathe in, because
so they go away from your hand.
Yeah, their chest is lifting their spine off the table. If they had really good opposition, so they had something like abdominals that are doing a good job, their pelvis is kind of neutral, it's, they have a pelvic floor that's kind of sitting in the right position, they take a breath in, especially if I tell them to, take a deep nasal breath. You should feel them lightly push down into your fingers as they take a breath in. And if they can't do that, then I just get them in a position and show them how to feel that. You see how when you breathe in, you actually smash my hand. You don't take pressure off my hand. And then they get that. And but I mean, that would be the difference between a little bit of a dysfunctional pattern and one that's more ideal. And when you see the dysfunctional pattern, a lot of times those people do exhibit kind of large deficits in thoracic rotation, because that extension essentially kind of locks that spine, its ability to rotate side to side. It kind of puts it in a kind of a fused state, pseudo state.
Right. The one thing I want to kind of clarify, the wide infrasternal angle, kind of the front beneath the sternum that kind of goes out left and right, where the abdominals kind of start, basically. What Bobby's kind of talking about with that is that sometimes you'll find that patients will lay on their back, or even I'll lay on my back or whatever, and you'll see those ribs kind of flare up in the front at rest. This is kind of a sign that is what's happening with what Bobby's talking about. Basically, those ribs are kind of coming up in the front, and they're probably stuck in the back. So there's not this teeter-totter seesaw kind of thing happening. They're not expanding in both directions. They've only expanded forward and up. This is also kind of, again, going back to my early days where I thought thoracic rotation was everything, and it's still a big deal, is a big hack with people to like touch their toes. If I saw that they had this big rib flare up in the front and could not touch their toes, it's almost as if the front of their ribs is overextended and they can't flex down at those ribs, right? So they're already starting at a loss. And just getting a little bit of thoracic rotation would help patients to touch their toes more simply, basically. And so that's the other idea, that basically if those ribs don't flex down, now again, which also is a combination of rotation, then they're going to have to get more of that flexion through their lumbar spine or elsewhere as a compensation. So kind of this expansion in all directions. The trick, I think, with thoracic rotation is that once we get you, there's this statement, Dan John uses it, Greg Cook uses it. If you can't breathe in a position, then you don't own it. And so with thoracic rotation, you may see patients that have 30, 35, 40 degrees of thoracic rotation left or right, but they may kind of get to the end and just have to bounce out of that. So being able to get to that rotation and then breathe in that rotation would tell me that they could extend and use either the back right or the back left, be there and breathe and expand in that direction. And sometimes it depends on the conditioning of the patient. Really, that's all you need them to do, is to get into that position and breathe there for a little while. Then, of course, with rehab, we'll go on this further, they need to sustain it with some strength exercises and whatnot. But yeah, simply put, I think that's what thoracic rotation is. What else did we miss?
Well, going back to your original question for me, you can have this, like, there's a certain type of patient where you could really understand this expansion idea, which would be if somebody comes into your office with maybe like a pretty severe anterior listhesis, maybe of L5 on S1 or something like that. They're very extended low backs. Maybe they have and I've seen this the worst on some of these spondies. So a bad grade 2, 3 spondy, extended low back, maybe somebody whose pelvis looks very far forward, chest up. Sometimes women can be even worse because they also have a chest to hold up. It's not really fair. Maybe they've had a few pregnancies that also weakened some anterior abdominal musculature or pelvic floor. Right. And now they're really extended. Mm-hmm. And I mean, I've had a few in mind where I will notice that they just have to stand. Maybe they'll stand in certain positions. If you lay them supine on the table, they just immediately put their hands over their head on the table. And you're like, and I'll just casually, I don't say anything. Can I put your hands here? And I'll put them down at their side. And then, go check whatever it is, hip internal rotation. And then 5 seconds later, they just, without thinking, put their hands behind their head again. And then I say, okay, can you just come over here? And I'll take one of those like aerobic step, like you do a step up class, right? Yeah. I'm like, can you sit on that step? And they just sit down there and I tell them to put their knees together and just kind of rest your head on your knees. And I've had a few patients that start to get panicky in that position. They can't breathe there. And that makes sense to me. And I'm trying to demonstrate it to the patient. But when you put somebody like that into a ball, you're basically blocking their ability to breathe because they're so forward breather. They're such a anterior breather that they cannot expand backwards. So when you close down their front, it's like me sitting on her chest and saying, take a breath in. And she, it'd probably be hard to breathe. So that's kind of what she's doing to herself by being in like a deep squat. So she can't breathe, cast a panic. And then this is where some of this clinical savviness can really help you out with your connecting to the patient. Because then I know that she, for example, this one woman is a rescue person. And she's always like looking for lost hikers and stuff. And I'll say, does it feel a lot easier to walk downhill than it is uphill? And she'll say, yes. How do you know that? And that's because you just showed me. You like to put your hands over your head and you don't like to be in a ball. And when you walk up a steep hill, you have to flex forward. And that's going to be harder for her to breathe. Mm-hmm. When you go downhill, you lean backwards and extend because you don't want to fall down the mountain. But that's how she breathes. So going downhill, she can breathe quite naturally and comfortably. And walking uphill, it's very difficult. And of course, she can't rotate because she's completely extended. And I think I've told this story before, but there we have a mutual kind of colleague from the PRI family who call these people crocodiles. He uses this example of, if you grab a crocodile's head and you lift it up into extension, they can't rotate and they can't eat you and they won't, you literally have them subdued. But if you let their head down and let their spine flex, now their rotation comes back and you're probably crocodile food. So yeah. So I don't call your patients crocodiles or alligators, but in a way I do hint at that.
Yeah. So, okay, this is perfect to move on from that to the next step. Like, how does thoracic rotation become dysfunctional? How does this anterior thing, this overly anterior breathing, kind of start? Let's go with that. And I'll take it. I'll take it so you can come up for some air for a second. A couple of the ways. Well, you kind of got into this earlier with the Wall-E thing, right? We're stuck inside. A lot of us are still, quarantined or living from home or working from home, I should say. Maybe not moving around as much this 2020 this year, but if we are sitting down a lot, then it's going to start, and we are slouched forward, it's going to precipitate that over anterior breathing, that anterior weight shift. That's kind of where our center of mass moves towards. And then it will lock up essentially that posterior spine because it's kind of on tension constantly, such that if we're sitting all day, and this is, if you're sitting for 6 hours a day, technically, you are classified as living a sedentary lifestyle, which is why we need to go to gyms, which is why we have treadmills and elliptical machines to try to make up for this. But regardless of that, the 6 hours a day of sitting is going to make us sedentary. And your body is going to look for the most efficient way to work within the setting that you're giving it, basically. It's going to go to was the physics thing you always like to quote, the lowest energy threshold, the minimum threshold of energy. It wants to level all that out. And so just breathing forward or breathing straight up. I know that a lot of chiropractors will see that the very active anterior neck musculature, you'll see SCMs kind of popping up and over dominant traps. It's a lot of levator trigger points, right, where they're breathing kind of straight up. But that's kind of the big reason. I mean, there's 1,000 articles on this, by the way, on Medium, like where bad posture contributes to a lack of, well, they'll say a lot of other things, but from a clinical standpoint, I think bad posture, quote unquote, just being in a position where you're slumped over too much, is going to diminish a functional thoracic rotation. Where do you fall on this one?
No, I agree with all that. I think, I mean, many things are flashing through my head, and some of
Yeah.
them more esoteric concepts like, narrow palates and things that we've
Yeah.
developed and being handed down through these recent generations of soft
Nearsightedness.
soft foods and all these things where we breathing, all these people that need CPAP machines to sleep and snoring issues, and how that breathing aspect starts to lead to dysfunctional postures, and the postures occurring because it's assisting your ability to breathe. At that point, it's at that point it becomes a necessity that you alter your posture so that things can happen, like you can breathe. So people stick their head forward sometimes so they can breathe. If they were to pull their head back, they can't, it'll close their airway off. So their jaws are retruded, which means you have to push your head forward so you can clear your airway.
Right.
But there's other things that are not so esoteric. Things like, I do think the sitting, I don't think it's just the sedentary nature of sitting. I think sitting is a substitute for squatting.
Mm.
And we used to squat. And when you squatted to rest, and you squatted to cook, and you squatted to eat, or even sit on a low log, which is much different than just sitting on a very high chair, for example.
Right.
Your pelvic floor moved, your iliums moved on your sacrum, so you could do things like counter nutate or roll your posterior pelvic tilt. Essentially,
Mm-hmm.
your rib cage could feel what it's like to come down, and you
Right.
could stay there and breathe. So people would sit there. I mean, and I've spent many a time in Asia, and you can see this in 80-year-olds selling newspapers in Hong Kong,
Right.
just in a perfect squat, and they can just sit there all day and sell newspapers. They haven't lost that ability because they somehow maintained it in their culture. So, but I do think the act of squatting, it's not like we need to squat because we want to power lift. Powerlifting is an invention by humans, but the squat is sometimes it's a it's not about how's your technique to squat and how do you do your setup and can you K-star screw your feet into the ground. Like, I'm not talking about any of that. I just mean the ability to unfold your body, to
Mm-hmm.
fold your body down into a squat, which again it creates a stacking diaphragm. It's basically like a respiratory diaphragm and a pelvic floor diaphragm, and causes expansion of the posterior rib cage. If you sit in a deep squat, you have to be able to do that. Otherwise you fall over backwards, or you need amazing ankles to do it. So I do think that alone is a big deal.
Right. No, and I agree with the concept ideally that when people are breathing the way that they're breathing, the anterior breathing or breathing up into their neck because of sitting, it's not a bad thing. It's not an ideal thing, but this is how the body has decided we have to breathe. So I kind of take fault with people who kind of chastise their patients for these findings, right? You're breathing up into your neck all day. They have to breathe during the day, and that is the way that they're getting in air. They have to be a mouth breather. That is the best way that they know to survive and get air in based on their lifestyle. That's kind of how it started. So they have to do that. Like, it's a good thing for a time that your body has figured out this kind of compensation. Some of these compensations, like breathing up into your neck or breathing forward, not in the squatted position, in the seated position, these things have a smaller limit basically, and you can run into a lot of other problems doing that. But I do think they are good things. That is the way the body is adapting. So I don't want to kind of put a horrible bad label on it. It's amazing that the body figured out that they need to elevate those anterior ribs and lock those back ones down. But yeah, okay. So now, go ahead.
Sorry, yeah. It's one thing. It's kind of like the quote I tell my patients. Like, they ask me about posture all the time, and I say, "There's no such thing as bad posture. There's just being in a position too long, or a position that you can't get out of." So it is good to be able to stick your head forward and breathe up and forward if you're doing a back bridge in gymnastics, because if it would be the opposite scenario where you can't breathe when you squat. Right. If you could only breathe backwards, well, then you couldn't bend backwards. You could never lay down in supine position and sleep, because you would be suffocating for air. It just so happens to be it's more of the reverse pattern that we see. But yeah, I mean, like I said, you want to be able to breathe in all these positions. You want to be able to neck breathe if you have to. But then you also want to be able to have a diaphragm that can breathe for you as well.
Right. Yeah. You want to be able to go in all directions. We just tend to go in one direction or a couple directions, and we leave some others out. So this kind of goes back to also, and we've said this a couple times already, you might be able to figure it out, but how do we improve thoracic rotation? So when we say thoracic rotation, we're talking a lot of anterior and posterior, but thoracic rotation is getting extension or expansion of the backside one side at a time. That's it. So you're just getting it at one side or the other. It's really hard to do it both sides at the time, because I will just say this as an intervention to patients. It's easier for them to just twist and kind of hang out there. Ideally, they would be able to flex the ribs down, back, and in, and feel some expansion on the back naturally. I've just found that thoracic rotation is just an easier way, for patients to kind of feel the difference left to right. And look, most of the time the patients you're seeing have unilateral pain. It's rare. They may have it on both sides, but typically they'll be like, it's worse on the right or worse on the left. And so I think thoracic rotation is a really good way to start showing them their imbalances and kind of motivating them to fix some of those things, right? Because a lot of times our patients get caught up on where the pain is, what the pain feels like, what it's stopping them from doing. And understood, you should not breeze past that sort of thing. But a good doctor will kind of show them the way, right? They'll kind of guide them to where they need to be, and then empower them. Like, look, you don't twist well back into the right. I just need you to do that more than you sit with poor posture at this point to open that up. Is that kind of a fair way? That's how I like to approach starting to improve that.
Yeah, I was going to say not just unilateral pain, but unilateral restriction is probably more common. Even if they're both restricted, they're just tight both direction, it's still more common to see one that's more restricted, whether it's left or right. Mm-hmm. So, and then that might, because again, just watching somebody walk, I mean, I just see so many claims that people make from observations of gait where I'm like, how do you know that that way they walk is because they skipped crawling when they were 7 months old? I mean, I don't know if that's true, but if you start to layer tests on top of each other, then you say, okay, I can see this unilateral arm swing where they really only swing their left arm forward really hard, and yet they can also rotate to the right, but they can't rotate to the left, but they also don't reach with their right arm very well. Okay, maybe they do have this restriction, or they have this asymmetrical position that they're in, and you can start to put these things together, and then you're going to be more confident that addressing that dysfunction may have some potential positive in restoring their function or decreasing their pain.
Yeah, we did that with the Craig Liebenson episode. We kind of went over some of his stuff, and we talked about how his big thing was finding the non-painful dysfunction. That was a great way into the the body system to start to make an effect. I saw one actually this week, treatment tip that was really good. I don't know why I didn't think of it, but there are flaws in it. But a patient kind of came in, and this guy had written their tests up on the board in the left-right comparison in terms of thoracic rotation, in terms of arm flexion, arm extension, internal and external rotation. So they took an accumulation of, let's just say, the right shoulder, external rotation, internal rotation, shoulder flexion, shoulder extension. They could have done abduction. They didn't, whatever. That's fine. Did the same thing on the left side, so it was even. And then they did thoracic rotation as well. And there was a clear, and then they literally just added all the numbers up. They're like, you've got 45. So your total range of motion equals this on the left, and a total range of motion equals this on the right. And so you can go with it a couple ways then with the patient. Why is my right side hurting and not my left? Well, if the left side has far less range of motion, the right side has far more, we can draw certain particular conclusions basically. Furthermore, especially this becomes tough when they're like, my right side hurts and it has more range of motion. My left side doesn't hurt. It has less range of motion. Does that really go together? What do you see with something like that, where let's just say the left side doesn't have as much range of motion as the right, and the right side does hurt? So this is going back to Liebenson's, fix the non-painful dysfunction. Like, where would we go with the treatment like that?
I'm reminded of Sam Harris using this expression of playing tennis without the net. Yeah. And I feel like we as clinicians do this. Like, yeah. So we say, you see how your right arm has less flexion? And you're like, which one hurts again? And then they're like, my left one. Like, yeah, that makes sense because, you use that one more because it has more mobility. So you overload that one. And if you would have said the right one, you said, yeah, see, that makes sense because it's restricted. So there you're causing an issue. I know we all do this and we don't mean to do it all the time. Yeah. It's not, we're not trying to be charlatans or anything. It just happens. Yeah. You just get in those positions where you're kind of caught off guard and you're like, oh, okay, it's the opposite one I thought it would be. But sometimes that's just how it goes. This stuff is so multifactorial. We don't always know. We always want to claim to know. And that's why it seems like some of the people who have been doing this for 3 or 4 years, they tell me that they know that the gate swing means this, which means they're compressing here and they're not able to bite their teeth on this side. And that's why they're impinging here. Yeah. And then when you get the person who's been practicing for like 25 years, they're like, I don't really know, but this side is really, he can't do this and he can do it on the other side. So I'm going to try leveling those two things. And also I noticed that his heel, his ankle mobility is really bad on this side, and the other side it's really good. That might have been from an old injury. So I'm going to try to balance those two things out. And I'm going to try to clear this stuff up first. And then I'm just going to pray that leads me in the right direction. Right. And you're like, that sounds more like the beginner clinician. But I think as you do this longer, you start to realize that you don't maybe have as close of an idea to what's going on as you think you do. So sometimes stepping back, I mean, Dr. Offenberger, we mentioned many times, he's like, until they can pass my hip extension test, don't come back to my office. Just come back when it's better, and then we'll see what else is going on. Right. And he's kind of doing that. He's kind of saying, yeah, I could pick apart all the little, idiosyncrasies of your body. Or I could say, here's a waving red flag that you don't have any hip extension yet. So I'm not even going to worry about, is your QL firing at the right moment and gait? if you can't extend your hip anyway. So
Right.
I don't know. It's just a little anecdote that I
No, it's
I'm
great.
coming to.
No, it's perfect. I forgot about that Sam Harris quote. I love that one. I think I might have used it before, but it's like oftentimes doctors will shoot an arrow and then paint a target around the arrow,
Yeah.
right? And look, and we kind of said it on our last podcast. We just keep referring to old podcasts. If you haven't listened to them, go listen to them. But like the idea is to not necessarily to understand precisely and exactly why the patient is where they are at. The idea is to help them go to where they want to get to. And you may not fully understand why they got to where they are, and you may not fully understand what all the tests mean and give the whole backstory to each one of the dysfunctions that you find.
Which is a good thing according to last week's podcast, right?
Correct.
Don't understand.
If you do understand and you give meaning to all of these things, then you're just adding a bunch more problems. The goal that patients are coming in because they want to go somewhere forward in life. They'll ask you about why did this happen, why that happened, and if you have a good idea, it's really only to say, look, hey, let's just keep it simple. Let's just say they know they shouldn't be sitting the way they sit all day, and you need to tell them to sit with better posture. That's fine, but the goal is not to uncover what happened before. They're really asking you, hey, moving forward, what do I need to stop doing to not get to this point again? And if that is sitting up straight or whatever, then it's really about asking a question to move forward. So don't get caught in trying to kind of live in the past. You're really just trying to help the patient get back to life. Cool.
Right on. What's next?
Who knows what's next? I got some notes down here. Let's check. Okay, so this is where we are going to excel at. So thoracic rotation. What if thoracic rotation doesn't improve, or what if thoracic rotation improves but doesn't help? Where do we kind of go from there? Like, okay, guys, I get it. Thoracic rotation is important. I'm going to kind of start looking for it. I'm going to be testing for it. I have some understanding of what's kind of going on and where it might be helpful for my patients. What if I do work on it and it doesn't help? Right? What are the first kind of things that you kind of start to look at? I mean, just to kind of clarify as well, sometimes, especially since we've both been practicing for a little while, we don't talk directly about thoracic rotation, but we do.
Mm-hmm.
So I'm thinking of, when I think of thoracic rotation, I think about it in the combination of shoulder extension, shoulder flexion, posterior expansion, posterior weight shift unilaterally. That's when that's my brain kind of dissects thoracic rotation in that sense, right?
Mm-hmm.
And so for me, if I do see that they have appropriate thoracic rotation, I start to look at the other side. I start to look at the appendages. I start to look above and below the joint. Depending on what the patient's, let's just say, symptoms are. I don't know if thoracic rotation is the core cause or an inability to, swing the arm. If there is, say, a problem in the shoulder, is the thoracic spine not letting the shoulder swing, or is the shoulder swing not letting the thoracic spine twist? So just those direct connections I'm kind of looking at. But in terms of muscles, so we've been talking about bones so far. What muscles are you kind of targeting, and just specifically with kind of thoracic rotation?
All of them. I mean, it depends. I mean,
Love it.
there's that's a tough one. I mean, because you have, like you said, you have arms that rotate.
Right.
You can rotate shoulder blades and arms on a rib cage, and you can rotate the rib cage underneath a shoulder blade. Some of the main movers sometimes would be things like the obliques,
Right.
but even things like the lat will turn shoulders on a rib cage. Serratus muscles can even do these rotational frontal plane combination moves. I mean, again, it just depends on the patient in front of me. A lot of times, like when we've been talking about people who can't rotate because of extension, well, one of the reasons why they might not be getting better or they're not able to improve their thoracic rotation is because they're still trying to they're still trying to learn to rotate on a spine that's not in a position to rotate. So that would be a person who feels very uncomfortable after doing thoracic rotation exercises.
Mm-hmm.
They might actually feel like those kind of rib pain knots after trying to do it. Their ranges of motion aren't really improving, especially permanently, maybe some small short-term gains and then it tightens
Right.
up again.
Sure.
That's because you haven't fixed a respiratory pattern, you haven't fixed a positional pattern to allow them to maintain any thoracic rotation. So I mean, a lot of times, you know, things that can work for somebody, like um, just, you know, the
Let-
ones where you're on hands and knees and put your hand behind your head and rotate your elbow up to the ceiling. There's people that there's no way they can do that. And if they are, they're already doing, they're in so much extension that that's just probably going to irritate them.
Right.
So I can do other ones like, I mean, you've talked about thread the needle, but instead of being on all just like hands and knees, like a bear position, I actually recommend for a lot of these people to push themselves back onto their heels, almost like child's pose in yoga. So they're actively pushing themselves away, which is like serratus activity. And then because they're pushing their butt back to their heels, they're counter nutating their pelvis. And then when they go to reach their opposite hand underneath one, you just Google this if you don't know it. But when they go to reach their hand through, they're actually flexing their spine slightly. And then their ribs can internally rotate, at least unilaterally. And they can, it might be more tricky to do it, but they're actually getting true rotation and something that might last. So again, it depends on the individual in front of you. You know, we talked about, I mean, you can, if you guys want to nerd out about this rib expansion stuff and angles that John's hitting on, there's somebody named Zach Couples that can't get enough of talking about this stuff. It's just, I think if he could just talk about infrasternal angles for the rest of his life, he'd be kind of happy. So
True.
there's endless podcasts if you want to go figure out respiration strategies and angles and narrow versus wide, and go ahead and dig into that to your heart's desire.
No, he's awesome with that. So, well, I'll throw a couple out. Well, let's go back to your example of the person who you got them to in short seated position to see if they could breathe and they had a little bit of a panic situation. That person, very overextended, cannot get the ribs down and back. In that position, Bobby was gone back to a structural position because he's not really loading any particular muscles, more or less. He's just putting her structure in a short-seated position so that she has to try to breathe through her back. This person, if they could get their ribs down and back, kind of what you're talking about, rocking back into the yoga position, if they could secure their abs, which you said earlier, which is a tricky one, right? The ribs being flared up in the back. If those abs could secure the ribs down in the front and they could get expansion in the back at rest, that would be a good thing. Or those serratus on either side, pulling the ribs down and back kind of laterally, or kind of where I was thinking as well. The one thing I do want to touch on, we do see a lot of thoracic rotation exercises or rehab on the internet. We had a post recently. Our friend of the show, Katie Clare, puts out one or two, a week. I don't know how she has so many thoracic rotation exercises. The girl's a library. It's crazy. But most of the thoracic rotation positions, that's the key, the thoracic rotation positions. You can sit and do thoracic rotation, and it means something completely different if you were to go to the position Bobby was talking about, on all fours, rock your pelvis back, and then try to twist. You would feel something very different if you then stood up and did a twist versus a half kneeling position. Each one of these positions, kind of like Bobby was talking about with the child's pose, is going to systematically lock up an area and force movement in another area. That's the goal of these rehab positions, whether they're on all fours or on the side, half kneeling, standing lunge position, doing a handstand or something, is really just the position will dictate where the kind of motion ideally should go through. Oftentimes it doesn't, and that's where we kind of run into problems. So I would say, there are a lot of people, the old school FMS people, test thoracic rotation kneeling. They test the arms laying on their back. They do it on all fours. They do it standing, and you can get different scores in each level. And each one will kind of dictate whether you get a motor problem or a joint problem. I know Charlie Weingroff goes into this testing thoracic rotation as more of a motor issue versus a tissue issue versus a joint is stuck in issue. So when you're testing these, find different ways to kind of look at it so that you're not just totally locking yourself up into just doing seated thoracic rotation, where you could get a lot of shoulder blade winging, and that could kind of disguise itself as thoracic rotation, basically. Man, we hit all the points.
Yeah, I was thinking at the end when you talked about testing. I remember,
Yeah.
I think I told this story before, but me and you were at a clinic together, or like a kind of like a continuing education course together,
Yeah.
and they were demonstrating thoracic rotation, and they were asking basically a volunteer to come up to show thoracic rotation, and we like a volunteer doctor to do the examination. And the doctor basically just had her sit there and then turn to the right and turn to the left. And you were over there, you know, scratching an itch like some meth addict, like couldn't handle watching it. So you just quietly walked up and grabbed a pillow and then just whispered to her, like, could you squeeze this between your knees, please, while you do this? And so she put the pillow between her knees, and then you just went back into the audience to like watch. In other words, you didn't even like address the class while you were doing this, but you couldn't handle that when they were evaluating her thoracic rotation, that the pelvis was moving with it. You know what I mean? So, and I was thinking at the time when I saw you do that, like, actually, I bet half the people in there didn't know why you did that. And that's fair, because we're not, you know, if you weren't taught that or you didn't come across it, well, that's fine. But I mean, you know, and before we started this podcast, you told me, think about, you know, the new doctor, think about the student. And I'm thinking, you know, you did that day to say, hey, we're not really assessing her thoracic rotation until she squeezes this pillow. In other words, let's keep her pelvis stable and then see if she can rotate her spine. And I think she went much less, and then even, you know, complained of a cramp of trying to rotate.
I think I remember
Because,
this now.
yeah. Anyway, I love that story. I like to tell that story just because of how you did it. You didn't like explain anything. You like just walked up there and then changed the scenario and then went back into the audience without really, you were no part of the scene, which was very funny to me.
You have to, if you're gonna test, then test right. If you want to test, then you want a pure test. If you're testing her thoracic rotation and hip, which is that's a great test. There's a PRI baseball course, which was awesome. We went to back in the day, and there is a test like, can you shift your hip back and rotate left and right? Can you shift your right hip back and rotate left and right? And I was doing that for a long, but because I was so set on like, no, you just need to keep the pelvis together. And you, dude, I get a little itchy when I see these things. I'm like, you're missing something. But then I also learned, here's me getting itchy again, then we'll stop this thing. But even if she does squeeze the pillow and the pelvis is locked up, quote unquote, it only means it's locked up. It doesn't mean that it's not asymmetrical. So I may have locked up an asymmetrical pelvis and then asked her to twist. So you still need to go into the pelvis if you're going to consider the pelvis with the squeeze of the pillow or not. Just for my itchiness, please do a thorough exam. And whether or not you start painting arrows around it or not, you'll get a better idea of what you're dealing with in front of you. Because if you don't test, it's just a guess. And at some point, we've said this before too, it is a guess. You're not going to know all the factors, and you have to go based off the information that you're getting from them, based off the information you're getting from the test. And then you're going to have to go forward and make an intervention of some sort. Look at thoracic rotation. Think about Itchy John. Do good tests. Listen to Bobby talking about breathing. Go check out Zach Couples. Perhaps on an episode of ours, we'll have to try to get him on the show. If you haven't subscribe. If you to our YouTube channel, subscribe. If you haven't rated and review us, I would very much appreciate it. Those ratings really help us get out there. Just go do something nice. You'll feel all warm and fuzzy after you do it. Give us 5 stars. But thank you for listening to your favorite podcast. We hope to talk to you soon. Have a great day. Peace.
See you guys.